Hi, I'm Dr. Greg Chajayan. I'm the owner and chief orthopedic surgeon at TJN Orthopedics and Sports Medicine. So today we're going to talk about knee pain. The first thing that needs to be done is an x-ray. Often people come to me with an MRI prior to having an x-ray, whereas all you needed is an x-ray to make your diagnosis. What's important to look on a standing x-ray is what's in between the bones. So when you take a standing x-ray, what we're seeing is the cartilage in between the two bones. That's both the articular cartilage and the meniscal cartilage or the fibrous cartilage. So that space is extremely important. So a standing x-ray typically should show that you have a space in between the bone. The space represents the cartilage. However, when you have no space between the bone, as in this x-ray, you'll see this is what we consider bone on bone. That means all the cartilage on the end of the bone has been worn off. So this is what we would consider osteoarthritis, which is basically wear and tear arthritis. This is in contrast to something we consider inflammatory arthritis, which is from a condition, say rheumatoid arthritis or lupus. These are conditions of arthritis that eat up your own cartilage. The way I describe treatments for people, for example, we're talking about knees, I talked about things in context of Band-Aids and things in context of fixes. Generally, fixes require operations. However, not everything requires an operation. Often we want to try to exhaust all conservative treatments first, such as Band-Aids. Now, just depending on the condition, now Band-Aids can get you 70–80% better often, and that's sometimes all that's needed. Everybody doesn't need an operation. You don't need an operation. You don't need to be sometimes 100% better because the risks that are associated with surgery sometimes outweigh the benefits to have the operation. So the treatments of this really depends on the severity of the arthritis that we're dealing with. If you have, say, a mild to moderate case of osteoarthritis, the treatments that we have are what we would consider conservative, non-surgical treatments. So this would include physical therapy, activity modification, injections, sometimes braces, and occasionally some people require using a crutch or a cane for a short period of time. But these are generally the non-operative approaches. Usually I advocate a low-impact exercise regimen, including bicycle, elliptical, swimming. These are all friendly type activities that people use in order to prevent knee injury. Running on your knee or jogging or hiking is not going to damage it. However, it's an impact. It's just going to create more symptoms. We're trying to reduce the amount of symptoms. If, however, your arthritis is on more of the severe category, we can consider using conservative treatments. However, I would consider that just a Band-Aid. So if we're talking fix, we're talking some form of joint replacement operation. Usually surgical treatments are going to be required in order to get into the 95% success rate. So basically, there are arthroscopic surgeries and non-arthroscopic surgeries. Arthroscopic surgery means camera surgery. So this is typically done for a meniscus tear, an ACL tear, a loose piece of cartilage. This is where we go with the camera. The size of the instruments are about the diameter of a pencil. We can go inside the knee, look around the knee, and repair what needs to be repaired. What's important to remember, however, is we don't have the ability to put back cartilage. So arthroscopic surgery generally is done to remove torn pieces of cartilage or to remove loose pieces of cartilage. However, if you've already have loss of cartilage from arthritis, we have no ability to put it back in. Sometimes we can consider what's called a knee manicure. We can go in and clean up parts of the knee, but it really has been shown not to increase the longevity of a person's knee, to just clean up an arthritic knee. So I don't generally recommend arthroscopic surgery for arthritis. However, depending on the level of arthritis, sometimes it just can affect one section of the knee. The knee has three compartments, a medial, a lateral, or a kneecap compartment. These are three individual compartments. So if arthritis, for example, exists only in one of those three, we could potentially just replace one of those three. Or in some cases, people are candidates for cartilage transplantation. If you just have an isolated defect, say it's like a pothole on the end of the bone, we can do what's called a cartilage transplant or an Oates procedure or a Carticel procedure. So depending on the kind of arthritis and the condition you have, there are plenty of options surgically. The ultimate surgery is a complete total knee replacement. It will solve the entirety of the problem, but it also means that you have arthritis throughout 2 or 3 of parts of your knee. So there's basically 3 criteria that I use to choose if you need a knee replacement. Number 1, x-ray finding. You have to have an x-ray finding that shows that you have narrowing of the articular cartilage between the 2 bones. So if you have an x-ray finding like this, one would need a knee replacement operation. So the 3 criteria are x-ray finding, your pain level, and your function or your decrease of function. So there are plenty of people who I see on a day-to-day basis who come in with advanced x-ray findings, however, have very minimal pain. If you have minimal pain and able to do all the things in your life that you're able to do, there's no need for an operation. We can't make you better than that. My job, what I do as an orthopedic surgeon, is to reduce your pain and increase your function. If you have minimal pain and good function, I can't make it better than that. So just don't treat an x-ray finding. The x-ray finding has to accompany significant pain and significant functional impairment. So that means that pain, you're having pain at night, you're having to take pain medicines, you can't sleep because of pain, it's becoming something at the forefront of your life, it's time to consider having a knee or hip replacement operation. And decreasing function means, for example, your friends or your family ask you to go on vacation, or they ask you to go to Disneyland with your kids or your grandkids, and you're unable to do life activities. These things, now you are compromising your ability to enjoy life, so then that will make you a candidate for potentially for a knee replacement operation. I've been doing this for 20 years, and when I talk to people every day about joint replacement operations, specifically their knee, somehow everybody has a misconception that we chop off the end of your femur and chop off the top of your leg bone and replace the whole bone. What's important to remember with hip or knee replacement surgery, it's not that. What I tell people, think of it like going to the dentist for a tooth decay. If you had a tooth decay, the dentist would remove the decay and crown the end of your tooth. That's pretty much what we do. We don't disrupt tendons, we don't disrupt ligaments. We go in, we remove 10 millimeters of bone on the surfaces of the femur and on the surface of the tibia, and we bond a metal object to the end of the upper and on the lower bones. In between those, there's a piece of plastic that's made of a polyethylene that becomes your bearing. Modern day hip and knee replacement surgery lasts 30 years. I've been doing this 20 years. I've never had to go back and change somebody's knee or hip out because they wore it out. So the future is bright in hip replacement and knee replacement because of our modern technologies. If you need a partner to help develop a strategy for your recovery, feel free to visit my website or call my office, and we would be happy to schedule an appointment for you. And if you want to find out more about joint health, check out other videos on my channel.